It's my pleasure to introduce a wonderful friend and colleague. So Dr. Linnea Baudhuin is a professor of laboratory medicine and pathology at the Mayo Clinic in Rochester, Minnesota, where she has been on staff since 2005. Dr. Baudhuin received her Ph.D. in clinical chemistry from Cleveland State University in conjunction with the Cleveland Clinic and has completed fellowships in clinical chemistry and clinical molecular genetics at Mayo Clinic. She is a fellow of the American College of Medical Genetics and Genomics. Dr. Baudhuin's clinical and research interests are related to genomic medicine and lie primarily in the areas of cardiovascular and renal inherited disorders, connective tissue disorders, and pharmacogenomics. It is definitely my pleasure to introduce her and welcome Dr. Baudhuin. We're excited to hear your talk.
So I'm really happy to be here. We have many years experience of testing inherited cardiovascular disorders, so I'm excited to share with you some of the things that we've learned. When you think about these disorders, they fall into four major buckets. We have cardiomyopathies, arrhythmias, aortopathies, and dyslipidemias, and we can test for pretty much all of these disorders. We understand many of the genes involved. For testing for these disorders, there's quite a bit of utility in testing for them. Obviously, diagnosis is one of them, and the diagnosis rate will be variable depending on what we know about the genetic basis for these disorders. There's also many considerations for how the genetic testing can affect proband management, and I'm going to share some cases with you today that demonstrate gene-based management approaches for some of these conditions. And then, of course, we always have predictive genetic testing in all of the cases. When we identify a variant within the proband, we can always test family members for that variant. So how do we do the testing? For the most part, we do targeted panel sequencing of genes involved in these disorders. And these are targeted because we're really only including relevant genes, but we do perform comprehensive analysis of each gene. This is in contrast to whole exome sequencing or whole genome sequencing, which can also be done. In those cases, you're obviously looking for many more genes or looking at many more genes. And in genome sequencing, you're including intergenic regions. The drawbacks to those two methods, even though you're looking at a lot more, is that it may not be comprehensive for the gene of interest. So you may miss something, sort of paradoxically, and may provide irrelevant or uncertain results, and also tends to be more expensive. Here at Mayo, like I mentioned, we've been doing genetic testing for inherited cardiovascular disorders for years. We first started in 2006 with familial hypercholesterolemia and then Marfan syndrome and related disorders. Our original methods were Sanger sequencing and MLPA to look for copy number variants in some cases. But we've currently moved over to next generation sequencing, which is a really nice method to use. And we now test for cardiomyopathies, arrhythmias, aortopathies, and connective tissue disorders, and dyslipidemias. So in July, this expert consensus statement on genetic testing for cardiac diseases came out, and I thought that was very timely to present to you some of what they stated because it's so recent. And it was also time for them to give an update because their previous consensus statement was in 2011. And they noted that over the past decade, there's been a lot of increased knowledge about the genetic etiology of cardiovascular disease. So we have obviously our rare Mendelian variants for monogenic disease, which I'm talking mostly about today, but then there's intermediate effect variants and there's common variants that can be aggregated to give polygenic risk scores for more common diseases. And I'll talk also about polygenic risk scores a little bit later in the talk. But what I really liked about this paper is that they gave some best practice guidelines for cardiac genetic testing. And I like this because it helped to emphasize things that we're already doing And so, what they recommend is phenotype-guided testing with evidence-based gene panels. So if you have patients with a clear specific phenotype, you can test them with for genes with definite or strong evidence and even moderate evidence and possibly even limited evidence. And then after that testing is done, if no genetic diagnosis is made, then broader genetic testing may be considered, including exome sequencing. But in patients with a weak or non-definite phenotype, genetic testing for genes with limited, disputed, or refuted evidence should not be performed. I'll tell you a little bit more about what this means in terms of the evidence for these genes a little bit later in the talk. And then they also say that, if your patient was tested in a pre-NGS era, it's probably important to repeat the testing in the current testing state. They also had really nice recommendations for variant interpretation and follow-up, which we're also doing here already. And I'll also talk about why this is so important in some cases that I'll present. So they recommend that variant interpretation in the clinical setting be performed by disease-specific multidisciplinary teams that include clinical disease experts, clinical geneticists, genetic counselors, and molecular geneticists, and we're doing that. And variant interpretation is best performed using standard guidelines for interpretation. So we use the ACMG guidelines that many other, probably most laboratories use, if not all laboratories, and can be enhanced by gene-specific rule specifications. This is a growing area, and I'll talk about this as well and some applications for that. And then also, in families where a likely pathogenic or pathogenic variant has been identified, it's important to perform cascade testing on family members. So in other words, look for that specific variant in family members. So I'm going to dive into the aortopathies. Marfan syndrome is a rare disorder. It's a multisystemic disorder, and there's a risk of sudden cardiac death due to aortic aneurysm and dissection. That's a major cause for morbidity and mortality. Marfan syndrome is due to variants in the FBN1 gene, which encodes for fibrillin-1. So FBN1 is a large gene. Variants can occur anywhere across the gene, and about 2/3 of the variants in this gene are missense variants and are considered to be dominant negative. So the most common variant in FBN1 is one that impacts a cysteine residue. FBN1, fibrillin-1 forms these microfibrils, and so proper folding of the monomers into the microfibrils is very important. Another dominant negative variant that can occur is that calcium binding residues, and there's others as well. And then the remaining 1/3 of variants are haploinsufficient variants, where they introduce a truncating mutation, say for example here, and it's going to create a shorter protein, and these are known as haploinsufficient variants. And we've studied these variants quite a bit, so I want to talk a little bit about what we've learned. So as I mentioned, these fibrillin monomers combine to form microfibrils, and they play important structural and functional roles in elastic fibers, and they act as stress-bearing entities. So you can probably see why disrupting these causes a multisystemic disorder like Marfan syndrome. So again, these haploinsufficient variants will lead to a reduced number of microfibrils, and the dominant negative variants will produce a stable abnormal protein and can have a range of effects depending on the specific variant. But prior to us publishing on these variants I think our first publication was 2015, prior to that, it was thought that these dominant negative variants actually led to a more severe phenotype than the haploinsufficient variants. So as I mentioned, we published on these, it looks like 2015, and we wanted to look at, is there a difference between these two variant categories, and do they impact phenotype? So we studied hundreds of patients that we had in our database with likely pathogenic and pathogenic fibrillin-1 variants. And we were surprised to see that in contrast to what was thought to be known at the time, the patients with the haploinsufficient variants were more likely to be Ghent criteria positive. So these are the clinical diagnostic criteria for Marfan syndrome, and more likely to have more severe cardiovascular complications. And since then, other publications have been published to confirm these and support these findings. And in fact, you can see here the association between increased aortic root diameter and the haploinsufficient variants, as well as aortic root dilatation rate occurring more rapidly with haploinsufficient variants. We were curious also to try and understand if there's a genotype-phenotype association in pregnancy because of the different stresses that pregnancy can induce, and also, the increased blood volume and those types of things. And so we took a look at what we had in our database in terms of women who had likely pathogenic or pathogenic FBN1 variants, and who also had given birth. And so we had 52 in our database. And what we showed, probably similar to what you'd expect based on what I just told you, is that in these women, they had actually a 4-fold higher rate of aortic events. So dilatation requiring surgery or dissection compared to the dominant negative type. In addition, we looked at the immediate peripartum period, so within 3 months of giving birth, because we did have a couple of cases where there were fatalities from dissection after giving birth. So we had 4 cases in total where there were dissections, 2 of them fatal, and all of those cases had haploinsufficient variants. There weren't enough cases to get the p-value down low enough, but still it was pretty striking in its own way. And then we decided to compare this to women who had never given birth, as well as males, and we saw a similar association. We did not see any differences between the different groups, though. So as I mentioned, the clinical diagnostic criteria for Marfan syndrome is the Ghent nosology criteria. And just like any other clinical diagnostic criteria, they are limited, even though they are, very good criteria. They've been revised over the years. They take into account all these different factors. But they are limited in that most, but not all patients with Marfan syndrome meet Ghent criteria. And then there's also patients who meet Ghent criteria but don't have Marfan syndrome. And so there's a differential diagnosis, there's phenotypic overlap. One of these disorders is Loeys-Dietz syndrome, and here's a picture of Bart Loeys and Hal Dietz with a Loeys-Dietz syndrome patient. And the overlap with Marfan syndrome can be striking in terms of the skeletal abnormalities, as well as aortic root aneurysm and dissection. But Loeys-Dietz syndrome is due to variants in a different set of genes. Similarly, vascular Ehlers-Danlos syndrome can overlap with Loeys-Dietz syndrome, so can be misdiagnosed. And this group of patients has variants in the type 3 collagen gene. So there's a lot of phenotypic overlap. So patients may present with overlapping features. They may be misdiagnosed based on clinical criteria alone. So I think you can see where genetic testing can help clarify diagnosis and help determine which gene is involved. And this group of disorders is really interesting because there's a lot of gene-based management that's known for this group of disorders, including frequency of aortic imaging, other vascular imaging, aortic diameter surgical thresholds, and then surveillance for other complications. And this is shown here in this table where you have the different genes across the top, and then the different management strategies. And this is actually, except for this column, which I added recently, this is actually all from 2010, so this has been known for a while. But we're really learning more and more about these disorders, these genes, variants, and how they can impact management. And in fact, just a couple of months ago, Diana Milowitz's group came out with a study for heritable thoracic aortic disease, which falls into this, aortopathy category. They looked at 7 genes and compared them to FBN1, so 8 genes total. And they had 1,000 patients that they looked at, and they divided the genes into smooth muscle cell genes versus transforming growth factor beta pathway genes. And what they found was that there was a significantly higher rate of type B aortic dissections with some genes. This is in contrast to FBN1. FBN1 dissections are almost always type A, so ascending aortic dissections, or type B are descending. But the type B dissections occurred at younger ages than type A. And there was a significant difference in the cumulative risk of aortic events and systemic complications amongst the TGF-beta genes. They also observed variant-specific risk for aortic events in some of the genes. So they found some variants that occurred in multiple patients, and they were able to make an association with aortic events. So this, further advances the field into, again, our knowledge of using genes to predict potential phenotype or events, as well as variants. So one thing that we've noticed, and other labs as well, I'm sure have noticed, is that there can be variability in how variants are classified. We're lucky in this day and age to have a really great resource at our fingertips. It's called ClinVar. ClinVar is a NIH open access database of variants and their classification. And so laboratories can deposit variant classification into this database. They can include reasons as to why they classified the variant that way. A lot of times they don't include information, but it's helpful when they do. And so there's hundreds of thousands of variants in this database. But one of the challenges with the database is that there are a lot of discordantly classified variants. So you might have one variant with 6 labs classified it, and it's classified anywhere from VUS to likely pathogenic to likely benign. So it's they can be all over the map. So because we have a lot of experience with FBN1, and we felt like we understood the gene quite well, we wanted to take a look at the FBN1 variants in ClinVar to see if we could understand the variability in variant classification. So we specifically looked at the missense variants because those are more difficult to classify. And we found about 1,400 unique FBN1 variants in ClinVar. And we divided them into critical versus non-critical region variants. So right here, this pie chart shows the distribution of the critical region variants. And I understand the wording is probably totally cryptic to you. But the majority of variants are cysteine-based variants. And those are more well known to be pathogenic, but there's a lot of other critical region variants that are probably less well known. And our data demonstrated that as well. So over here, these 2 bars have so these are all the different critical region variants and how they are classified. So we're looking for the percent that are classified as likely pathogenic or pathogenic, and if they're a critical region variant, they should almost all be 100% classified as likely pathogenic or pathogenic. So you can see already this variability. Because, like I mentioned, the cysteine variants are more well known, we did see, so this is just an overall cysteine-related variance, we did see that 91% of those were more likely to be appropriately classified. Looking at the non-cysteine critical region variants, you can see that they're much less likely to be appropriately classified. In fact, they were misclassified 40% of the time. So this was striking to us, and hopefully with more education, these can be classified properly, over time. We also, like I mentioned, looked at the non-critical region variants. So these would be missense variants in regions not known to be important for function of fibrillin 1. These are also more tricky to classify, and there's usually less information available about them. But if you look at the minor allele frequency of these variants in large databases like NOMAD, it can really help guide whether or not these variants are reportable or involved in disease. So the blue bars are the ClinVar-based classification. So we have likely benign, variant of uncertain significance, or likely pathogenic and pathogenic. And when we applied our gene-based knowledge and minor allele frequency, we actually reclassified over a quarter of them as likely benign. And these would be non-reportable, if we saw them. So, really there was a significant number of overclassified variants in ClinVar. And this is really important. Obviously, you can think of many reasons why. If you're telling a patient that they have a likely pathogenic variant and it's really a VUS or likely benign, they might think they have an answer. They might test their relatives. Their relatives could get tested and they don't have the variant, so they think they're not at risk. But when in reality, we don't really know yet what's causing their phenotype. And another way that this variant misclassification can impact things is that it can impact the estimates of disease prevalence. And this is important because we need to know disease prevalence in order to do some calculations to determine variant pathogenicity. So it kind of is a circular thing. So if you overestimate a variant's pathogenicity, you're going to overestimate disease prevalence. And there was a paper that we think did this, and we wrote an editorial, a letter to the editor about this. And this was from a 2015 paper where they stated that hereditary hypertrophic cardiomyopathy prevalence has been greatly underestimated and could be as high as 1 in 200. And up until that time, it's been long thought that the prevalence was 1 in 500. So they based this mainly on this 1 in 200. They based it mainly on some genetic variants that had been classified in 2012 and had been classified as likely pathogenic or pathogenic. Well, we were really curious about this because now it was 2015, it was 3 years later. There's actually in that short time period, a lot more was known about, again, the minor allele frequencies of different variants across large populations. So we took a look at those variants and we determined that almost 73% of them were overclassified. So they really should be VUSs, maybe even likely benign. And by doing that reclassification, it brought the HCM prevalence back to the normal 1 in 500. So here's a case that I wanted to share with you, again, pointing out the importance of proper variant classification. And this is a really interesting case. So this was a 16-year-old female who, a male patient who presented to clinical genomics with in 2018 with joint dislocations, chronic muscle and joint pain, extreme joint hypermobility, soft velvety skin, easy scarring and bruising and striae. And based on the clinical criteria, she was diagnosed with hypermobile Ehlers-Danlos syndrome. Her family history was that her brother and mother are very flexible with elastic skin, and her mother has had back and hip dislocations in the past, and there are other maternal relatives known to be very flexible with or without elastic skin. So again, this hypermobility. So based on all of this, it was decided that she could undergo genetic testing for utilizing an outside laboratory known as Invitae, utilizing their Ehlers-Danlos gene panel. And her results came back, and she had 2 variants of uncertain significance in 2 collagen genes, COL1A1 and COL5A1. So in follow-up consult, her genetic test results were discussed, and it was thought that maybe she could undergo whole exome sequencing with her parents to see if anything else could be detected. So she underwent proband parent trio whole exome sequencing through GeneDx and got the same results back. But this time it was determined that both of those variants were maternally inherited. So I want to talk about the COL1A1 variant because that was something that we found later and determined to be of importance. So, collagen is a heterotrimer comprised of 2 alpha-1 chains encoded for by COL1A1 and 1 alpha-2 chain encoded for by COL1A2. And in these genes, these genes are most commonly found in osteogenesis imperfecta, but also rarely in Ehlers-Danlos syndrome, as well as a fairly newly described disorder known as OI-EDS overlap. And similar to FBN1, these genes can have dominant negative and haploinsufficient variants, but the most common variant is going to be missense substitution of a glycine in the triple helix GlyXY sequence. So you can see these GlyXYs going across the chain. The glycine is important because it's really small, and there's not very many amino acids that you can substitute that are that small. And so if you introduce a larger amino acid, it's going to cause kinks in the chain and create a dominant negative effect. So the patient in the case has an arginine to cysteine variant, so it's not a glycine variant. But it is actually known that arginine to cysteine variants are important in COL1A1, and it was known at the time of testing as well. So arginine to cysteine variants cause a rare form of classical Ehlers-Danlos syndrome known as classical EDS with vascular fragility. And it's really important because they can have vascular ruptures, which usually occur in the 3rd to 4th decade. And the reason why this type of variant is thought to create a phenotype is because if you look across the triple helical region, you won't see cysteines. And introducing a cysteine results in spacing abnormalities and as well as the creation of disulfide bonds within the heterotrimer. So again, creating a dominant negative effect. So we came across this case somewhat accidentally. We were doing a study. So we also have an Ehlers-Danlos panel. And we noticed that we had some really interesting cases come across our way of what looked to be like the OI-EDS overlap syndrome, and they had variants in COL1A1 and COL1A2. So we wanted to take a deeper dive to see if we could understand this OI-EDS a little bit better because it was so new, and we wanted to try to understand the genotype-phenotype correlations more. So we looked at all of our COL1A1, COL1A2 cases that we in our lab. We also partnered with Dr. Knight. He runs the EDS clinic in Mayo Jacksonville. And we also looked through the electronic health record here at Mayo to find these cases. And as part of that latter activity, we came across this case. And as part of what we were doing, we were looking at these variants. We wanted to make sure that they were properly classified, so we reanalyzed all of them. And we found this arginine to cysteine variant in this one case and saw that it had been classified as VUS, and we were like, uh-oh, it's actually likely pathogenic. Interestingly, earlier this year, Invitae did submit a revised report for this variant where they reclassified it from VUS to likely pathogenic. However, also interestingly is I don't see anywhere in the report where they mentioned this is an association with classical EDS with the vascular fragility. So they mentioned that it looks like they reclassified it based on that they had seen individuals with clinical features of EDS and this variant, and that the variant segregated in disease in families. So now that the family knows that they have this likely pathogenic variant, it likely provides an answer for them, and it impacts clinical management, not only for the proband, but for her mother, who is in her late 30s or early 40s by now. And it allows for cascade testing in other family members. So this, so hopefully I've shown you that, many different examples of how laboratories can classify variants differently and why it's so important to, as the expert consensus guidelines recommend, to have disease-specific multidisciplinary teams that are interpreting variants using standard guidelines and gene-specific rule specifications. I want to talk now about including clinically relevant genes on our panels, and this is a really important area. So this figure gives you, kind of a depiction of, if you include bad data or bad genes in your test and you have the best ever analysis, the perfect analysis, you're still going to get bad results, kind of the garbage in, garbage out the model. And I'll use, in this case, I'll use arrhythmias as an example for the importance of including clinically relevant genes. So heritable arrhythmia syndromes are dysfunctions of cardiac ion channel subunits or the proteins that regulate them. There's several different examples of heritable arrhythmia syndromes. This is a picture of a prolonged QT interval by EKG, and that's characteristic of long QT syndrome. And these individuals are at risk for syncope and sudden death. The genetics of arrhythmias are complex and heterogeneous. So most of them are autosomal dominant, but there are also autosomal recessive forms. They can be clinically heterogeneous, and it also can be confusing to know what the underlying cause of the arrhythmia is, because there's many different things that can cause arrhythmias, including different medications. So they are very genetically heterogeneous, and numerous genes have been identified as potentially involved in these disorders over the years. Most of these genes are highly polymorphic, and most variants identified are missense variants. So there's, again, this, heterogeneity to even our understanding of the genetics of arrhythmias. And there's a large percentage of arrhythmias that are thought to be hereditary with unknown genetic causes. So our current offering for arrhythmias, which is going to be revised and updated in November, we have two tests, one for long QT syndrome, that's 13 genes, and one for Brugada syndrome, which is 9 genes. And as we were, going through updating our panels, we obviously wanted to include genes that are clinically relevant. So we're really lucky, again, in this day and age, to have ClinGen expert panels. And ClinGen is Clinical Genome Resource. It's the same entity that houses the ClinVar database. So these ClinGen expert panels are comprised of international experts who perform gene curation and variant curation. And with the gene curation expert panels, they evaluate genes to determine gene disease validity and causality, and they determine whether genes are definitive, strong, moderate, limited, or disputed. So there is a ClinGen expert panel for long QT syndrome, and they published on this in 2020, and they took a look at 17 genes that were thought to be involved in long QT syndrome. And only 3 of these genes were curated as definitive genes for typical long QT syndrome, and 4 of them were curated as definite or strong for causality in long QT syndrome with atypical features, including neonatal atrioventricular block. 1 gene has moderate evidence, 3 genes have limited evidence, and then the rest are disputed. So our new long QT syndrome panel does not include 13 genes, it includes 11 genes. Similarly with Brugada syndrome, and I thought this was really interesting, this expert panel looked at, these are all different variants that have been identified to be associated with Brugada syndrome. And they looked at each individual variant and found that only SCN5A had pathogenic or likely pathogenic variants. So going from 21 genes potentially associated with Brugada syndrome down to 1 definitive gene, and the other 20 genes were actually classified as disputed. So our new Brugada syndrome panel, which is not a panel because there's only 1 gene, just includes SCN5A. They also went in to say that routine genetic evaluation of genes other than SCN5A is not currently warranted. And I thought this was really helpful to read because it really brings home the point of why we need to include appropriate genes. Genetic testing of genes without sufficient evidence supporting causality for Brugada syndrome may lead to incorrect interpretation of rare variants in these genes and inappropriate diagnostic conclusions or interventions for patients and family members. Okay, so I'm going to talk about precision medicine and cardiology. So precision medicine is the customization of medical treatments to the individual patient. There are several examples of precision medicine with hereditary disorders. So for example, in long QT syndrome, this group of patients are often given mexiletine. This group of patients can be given lumacaftor or ivacaftor. Patients with CPVT are given nadolol or propranolol. With the HCM phenocopy, Fabry, these patients can be given enzyme replacement therapy. Patients with familial hypercholesterolemia can be given anti-PCSK9 inhibitors. And then there's also pharmacogenetic applications, for example, for warfarin, statins, and clopidogrel. And I want to talk about clopidogrel because we did a huge study here at Mayo, and I was involved in it, so I want to tell you about it. So patients who undergo percutaneous coronary intervention usually have a standard of care for treatment where they're given dual antiplatelet therapy, which would be aspirin plus a P2Y12 inhibitor, usually clopidogrel, but sometimes prasugrel or ticagrelor. The purpose of this is to prevent adverse ischemic-related events. But as you can imagine, there's an increased risk of bleeding when you're given these antiplatelet therapies. There's also inefficacy that can occur, so may not have enough antiplatelet effect. So a balance between ischemic and bleeding risk really needs to take place. And even though clopidogrel is standard of care, it does have suboptimal platelet activation in about 30% of patients. And this is largely due to loss of function variants in the gene known as CYP2C19. So clopidogrel is given as a prodrug where it's inactive, and then it's activated by CYP2C19 and some other enzymes to its active metabolite. And as I mentioned, these loss of function variants in CYP2C19 can lead to inefficacy, and this has been known for some time, but pharmacogenetic testing for clopidogrel has been lacking, or not lacking, the uptake for it has been lacking because up until this point there were no large prospective trials looking at this. Well, Taylor PCI changed that, and this is again a trial that was initiated here at Mayo Clinic. It's the largest prospective clinical trial on this topic, genotype-guided clopidogrel therapy in the world. It's an international prospective randomized trial utilizing 40 different sites. It was a huge undertaking. So this trial looked at patients, about 5,300 patients undergoing PCI, and they were randomized to standard of care, which is clopidogrel, or genotype-guided antiplatelet therapy. So this group of patients were tested for CYP2C19. If they had a loss of function variant, they were given ticagrelor. If they did not have a loss of function variant, they were given clopidogrel. And then after 1 year, all the patients were genotyped in both arms of the study. And the primary endpoint was at 12 months, and it was a composite of cardiovascular death, MI, stroke, stent thrombosis, and severe recurrent ischemia. A secondary endpoint was major or minor bleeding at 12 months. And the trial was really strongly powered. It had 85% power to detect a minimum hazard ratio of 0.5. So the publication that came out in JAMA showed that there was actually no statistically significant difference in composite endpoint at 12 months. And it was pointed out that there was this really kind of major limitation in that this very ambitious 85% power to show a 50% reduction in primary endpoint, considering the number of cases with events. But it did show a 40% reduction for cumulative primary endpoint. Additionally, a secondary analysis, which is currently under review, demonstrated that cumulative ischemic events were significantly decreased at 12 months. And this was really important. At the 3-month time point, not the 12-month time point, there was a statistically significant decrease in adverse events, in fact, an 80% reduction. So it really points to the potential benefit of genotype-guided clopidogrel therapy, especially early after PCI. And in fact, based on these results, the cardiologists here at Mayo are very interested in doing this testing, and we're working towards developing a more rapid method to do this analysis. We currently have a test for CYP2C19 genotyping, but it takes a couple of days, and we'd really like to be able to provide them with same-day results. So we're working towards that. Okay. Finally, just a few minutes to talk about polygenic risk scores, and I want to talk about this because it seems to be a really hot topic. A lot of people are interested in it. We get a lot of questions about the utility of polygenic risk scores for CHD. So what are polygenic risk scores? They're really, so polygenic risk scores have been developed through GWAS studies, genome-wide association studies, looking at common genetic variants across the genome. And then the variants can be aggregated to produce a score looking for genetic predisposition to a specific trait or disease, so predicting disease, predicting adverse outcomes, and prediction of response to therapy. So again, Polygenic risk scores aggregate the many small effects of variants across the genome to estimate an individual's disease risk or other risk. In terms of coronary heart disease, CHD, I'm sure you've all heard of, CHD running in families. It does have a fairly high estimated heritability. And monogenic CHD disease is rare. The most common monogenic CHD disorder is familial hypercholesterolemia, and it's about 1 in 200 to 1 in 250 in the population. But heritable risk for CHD is mostly thought to be polygenic. So that's where these polygenic risk scores come into play. And in fact, some studies have shown that the polygenic risk score is associated with CHD, independent of clinical risk factors. However, other studies have shown that it does not add value beyond the Framingham risk score. So if the Framingham risk score is a compilation of age, sex, smoking status, cholesterol, blood pressure, and whether or not the blood pressure has been treated. In addition, there's some little bit of controversy about the utility of polygenic risk scores. In addition, outcome studies are lacking. So to date, I don't think there have been any outcome studies for polygenic risk scores. There's also a lack of standardization across the study. So every study uses a different set of variants, a different way to calculate the polygenic risk score. And a major limitation to polygenic risk scores, not just in CHD, but across all different applications, is that most of our genomic studies have been done in Europeans. So we have a lot of information on the genomics of Europeans. And if you look at polygenic risk scores across non-European populations compared to Europeans, you can see that there's really a reduced accuracy in their predictive ability. And not only across ethnicities, but even within ethnicities, you'll see differences. So, for example, this is looking at a European population stratified into Ashkenazi Jewish versus non-Jewish European, and you can see the polygenic risk score for CAD is significantly different. And this actually goes across many different disease states: atrial fibrillation, breast cancer, IBD, and type 2 diabetes. So it holds true for all of these disease states. So while PRS, is a promising tool to use, we really need diverse biobanks to help improve PRS accuracy and clinical trials, to look at outcomes, and do larger studies of these polygenic risk scores. And from a laboratory perspective, the genome-wide polygenic risk score is challenging to implement. It depends on the technology that you're using. If you're going to do a GWAS or you're going to do whole genome sequencing, it could get very expensive. Also, these ethnicity-based algorithms are difficult to develop and complex, and if they're based on self-reported ancestry, we may not get it right. So we may even have to use, like if we're going to do genome sequencing, maybe even have to use the genome sequence to determine the actual ethnicity of the patient. There's a lot of regulatory considerations. You have this black box algorithm working behind the scenes to calculate this polygenic risk score. It's, questionable clinical utility, questionable clinical validity. So there's going to be a lot of regulatory concerns. And then reimbursement is also another question, because if there's really not a proven clinical utility, it's unlikely that this test will become reimbursed. So in summary, I've shared with you that there are many different hereditary cardiovascular conditions. A lot of them have phenotypic overlap, so genetic testing can be really helpful in properly identifying the diagnosis, as well as the prognosis, in some cases management, and in all cases familial testing, especially if a variant is identified. I've shared with you that it's really important to include clinically relevant genes on panels, and that gene-based knowledge is very helpful for variant interpretation and classification. I've shared some precision medicine and pharmacogenetic applications, especially clopidogrel, and that polygenic risk scores have promise, but there are many hurdles yet to overcome. And finally, I'd like to acknowledge an amazing team of individuals that I work with. Most of them I work with on a daily basis. I'm very fortunate to work with all of these experts and these individuals who are so generous with their time to help our patients.
Excellent. Thank you so much, Dr. Baudhuin. I got the Slido up and we have a couple questions in. So the first question is there an EDS clinic in Rochester?
Not that I'm aware of. The only one I know of within the Mayo system is in Jacksonville.
And that was the one that you collaborated with for your research, right?
Yeah,
Excellent.
Dr. Knight, yes.
Is there an age you would suggest children to be tested if they come from a known EDS line and possibly show early symptoms?
I do not have the clinical knowledge to answer that question.
Yeah, I know that's a great point. Is we work here as in collaboration with our colleagues, and sometimes some of those questions really kind of go more in their direction than ours. And another question we have here is, with diverse sets of panels available, some outdated, why not do whole genome studies versus whole exome or whole gene with introns so that tests are not repeated?
Yeah, that's a great question. And I think it boils down to cost. So, if we're doing whole genome, that's the most expensive method that we can do. And whole exome is also expensive. So the targeted panels are the least expensive, and they're really nice to perform, especially if there's the phenotype is more clear. The targeted panels are great because we look specifically at those genes, we look at the clinically relevant genes, and we can look at the gene comprehensively. So with exome, even though it says whole exome, it's not really whole exome. That test can miss certain regions of genes. And so, like, let's say, for example, your patient has what looks to be Marfan syndrome, and you want to look at FBN1. Well, FBN1 in the whole exome may be missing parts of exons, so you wouldn't get the comprehensive gene analysis, and it's also more expensive. Whole genome is comprehensive, but it's even more expensive. And when patients need to pay out of pocket sometimes, it's definitely usually a deal breaker. And then you're getting so much more information back with exome and genome that sometimes it takes a long time to go through the data, as our laboratory can attest. And sometimes you may be providing answers back or results back that are of uncertain significance. You may be giving genes of uncertain significance or variants of uncertain significance, and that just creates confusion. So I know that Dr. Heidi Rehm spoke last week, and she did some studies that showed that you're actually giving fewer unsignificant results back when you do whole genome or whole exome. But I think that's because you don't report back variants of uncertain significance oftentimes with those tests. So I still think that targeted gene panels are the way to go, especially if you have a pretty well-defined phenotype.
Yeah, I really like how you highlighted there. There's a couple of other practical considerations. It's a nice idea, but in terms of the analysis, in terms of the cost of the test, in terms of being clear with our clinical colleagues and our patients, the results. Well, we are out of time, but thank you so much, Dr. Baudhuin, for giving grand rounds to us.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.